Hello, my name is Arthur Yue. I'm a cardiologist and electrophysiologist in Southampton. My talk is about fluoroscopy SVT procedures in children. First of all, I would like to thank Arrhythmia Alliance and the expert panel for recognizing our work. And we are absolutely thrilled to be awarded SVT Pioneers 2022. I would also like to acknowledge my dear colleagues, Dr. Shankar Sandagopan, Phil Banks, and Dr. Nora Yap as major contributors to this work that I'm going to present. And without whom, it would not have been possible. Now, all three types of SVTs occur in children, just like in adults. And they can be very fast and debilitating for the patient and detrimental to their development. Antiarrhythmic drugs can be tried first, but could be a major concern due to side effects and the restriction of sporting activities. Now, catheter ablation offers potential cure for SVTs in over 95% of cases and is now preferred treatment, especially if patients have a satisfactory body weight. One major issue with this treatment modality is the dependence of fluoroscopy or X-rays historically, often with prolonged duration in children. In a large registry in children, about 20% of cases needed over 50 minutes of fluoroscopy. And this poses significant radiation risks, ranging from dermatitis to even malignancy to staff and children who would otherwise have a long life expectancy. But even if you can cut down fluoroscopy time, all staff still have to wear lead aprons, which can cause orthopedic injuries. Nowadays, we have 3D mapping technologies to help with ablation, but they are rarely used without fluoroscopy, mainly because of unfamiliarity and concerns with transeptal access in children. There were only a few studies and publications on zero or limited fluoroscopy ablation in children. Some are limited to just accessory pathway ablations, just right-sided procedures, excluding transeptal access, or that they could not display the transeptal needle on 3D mapping. So in our report, we have retrospectively gone through our experience of SVT ablations or EP studies in children. We started in 2019, but it was after the first COVID wave that we performed fluoroless ablation for children routinely. We completed our first 100 cases in March this year, with another 20 or 30 or so since then. The mean age was 13, with the youngest being 5 years old. And it was a comprehensive program as we included all comers and all forms of SVTs and diagnostic studies. You will see on this slide the distribution of the different forms of SVTs in this cohort. And as you would expect, nearly half were accessory pathway mediated cases, including Wolff-Parkinson-White syndrome and concealed pathways, labeled here as AVRTs. About a third were AV nodal reentrant tachycardias, and less than 10 cases of atrial tachycardias. In terms of mapping systems, we have mainly used the CARTO system and a little bit with the EnSite system, but we have also done some adult cases with Rhythmia as well. The mapping catheters for CARTO and EnSite, called hand-to-ray and HD-grid, are both very soft and safe catheters in maneuvering in the heart without fluoroscopy because they change shape when in contact. The main difference is that the ablation catheter in the Carto system also provide an icon of the vector to show directionality of the tip contact, which makes us feel more comfortable in a smaller heart with tighter space. And Carto also integrates better with intracardiac echo. In our first 100 patients, 88 of them underwent ablation and 12 only diagnostic studies. Transeptal access was necessary in 20 cases due to left-sided pathway ablations or atrial tachycardias. And although we started with transesophageal echoes, we quickly moved on to intracardiac echocardiogram, because as operators, we have complete control over what we need to see, and we do not require additional manpower to do the same job. And as the intracardiac echo probes are as small as 8 French, we have used them for children as young as 7 years old. So this is what a fluoroless EP lab looks like. You can see that no one is wearing lead aprons and everyone is relaxed, chilled, and focusing on the case. Number 1 is my colleague, Dr. Sadagopan, who was the first operator of that case. And number 2 is me, the assistant. But as you can see that the image intensifier is out of the way, and you can fit in another person or 2 as trainees that you can work very closely to the main operator to learn. Number 4 is the anesthetist, who is particularly happy not to have to wear lead. Number 5 is the nurse. And number 6 is the radiographer, who is able to do some admin work because we are not screening. And here's how we start a fluorous case. A catheter with magnetic tip sensor is inserted from the groin vein into the inferior vena cava. And very soon, you see it appearing in the mapping system as a shell or image of the vein as is being tracked and created for reference. When you reach the right atrium, the atrial signals will be recorded, and when the catheter reaches the SVC, you will lose the signals. So you just pull back to the right atrium. We then create a quick shell of the right atrium. Usually takes less than a minute, in order then to gain access to the coronary sinus to visualize the signals from the left atrium. And this is often made easier because the coronary sinus ostium is seen as a stump, as a guide, whilst we are moving the catheter in the septal area of the right atrium. But the novel aspect of our series is that we combine the use of intracardiac echo with visualization of the transeptal needle for left-sided cases. Hence, we have 2 ways of simultaneously guiding transeptal access, which we feel is extremely important to improve the safety of this procedure. And here I would like to demonstrate to you what it looks like to visualize a transeptal needle tip on a 3D map of the right atrium and the superior vena cava. And you can appreciate that the needle tip in blue is being slowly dragged downwards from the SVC to the atrium, the atrial septum, seen from a modified left lateral angle. And when the needle is down at the heart level, the intracardiac echo nicely confirms the position, attending the septum. And after transeptal access, the intracardiac echo also shows the guide wire in position, as you see here, indicated by the yellow arrows, followed by insertion of a sheath, as shown by these blue arrows. Then the mapping catheter. And these are just two examples of different arrhythmias that we have mapped and ablated. On the left side is an atrial tachycardia spreading from a focus in the tricuspid valve annulus. On the right is an example of a tachycardia impulse going from the ventricle to the atrium through an accessory pathway. In terms of clinical outcomes, we have not experienced any acute complications, but we have elected not to ablate 4 cases of proven arrhythmias, mainly because of the proximity to AV node in asymptomatic patients with accessory pathways or close to coronary arteries. And for those we attempted ablation, we have been able to achieve complete procedural success. At short-term follow-up, we have an approximately 5% recurrence rate. So in conclusion, zero fluoroscopy EP procedures, including left-sided ablation in children, are entirely feasible, safe, and effective. We feel that by combining the use of 3D mapping systems and intracardiac echo, we can achieve a level of safety and reassurance for routine transeptal access in smaller patients. So we very much hope that more centers in the UK and abroad can do this as well. Thank you very much for your attention.